Good day. So this is a presentation on the different disorders that are related to primary hemostasis. So that means the platelets and the blood vessels. Make a diagnosis of bleeding problems. There are questions that must be addressed, like, is there a presence of bleeding tendency? Is the condition familial or acquired? Is the disorder one affecting is primary or secondary? Is there another disorder that are present which could be the cause of or might exacerbate the bleeding tendency? Secondly, there are different presentations, physical presentations of bleeding disorders. For example, easy bruising. We will be discussing each of these one by one in the next slides. Second is spontaneous bleeding from the mucous membranes, menorrhagia, so that means the excessive bleeding during the menstrual cycle, and excessive bleeding after a traumatic event. One of the principal manifestations of bleeding tendencies is bruising. It could be with mild trauma or even without trauma. We can see in these slides some of the manifestations of bruising, like petechiae, ecchymosis, and hematoma, so which take place without trauma, without the presence of a traumatic event. The bleeding that are manifested in the mucous membranes and menorrhagia, as we have explained earlier, are also principal manifestations of bleeding tendencies, and some examples include epistaxis, which is the medical term for nose bleeding, gingival bleeding, gum bleeding, hematuria, hemoptysis, hematemesis. Hematuria, of course, is the presence of blood in the urine. Hemoptysis and hematemesis is coughing out of blood, which could come from the respiratory or the gastric tract. As a bleeding that happens after surgery, dental extraction, tonsillectomy, and delayed wound healing, and even postpartum hemorrhage are again signs that there may be some bleeding tendencies. Bleeding in the joints and in the muscles may be present in bleeding tendencies. The term we have for joint bleeding is called hemarthrosis, and in muscles we just call them hematomas. The presence of bleeding in these two organs may represent deficiencies in certain plasma proteins and even in hemophilias, different types of hemophilias. So that is also a type of clotting protein, clotting factor deficiency. This is not exactly a common thing for other bleeding disorders, except in severe cases of von Willebrand's disease. Bleeding disorders may be because of a problem with the formation of the primary platelet plug formation, the fibrin formation, or premature dissolution of the blood clot or fibrinolysis. In this case, we may observe the presence of petechiae. This is because of very low levels of platelets and or spontaneous hemarthrosis. Again, this may be because of deficiencies in certain clotting factors. To screen for bleeding disorders, we can perform prothrombin time, APTT or activated partial thromboplastin time, and quantitative platelet counts. We can also perform bleeding time and thrombin time. In this table, we can see the findings in primary hemostasis if we are to perform the previously mentioned laboratory test. If it is a vascular disorder, if there is a problem with the blood vessels, the platelet count is expected to be normal. The prothrombin and the activated partial thromboplastin time are both normal, while the bleeding time may or may not be affected. So that means it can be normal or abnormal. If the platelet level is very low, so that term is thrombocytopenia, of course we expect that the platelet count would be decreased. The PT and APTT remains normal, while bleeding time is also affected because the platelets are the ones responsible for forming the platelet plug, which will later stops the bleeding. So if there is not enough platelets available, we expect that the bleeding time will be lengthened. Next, platelet dysfunction. So if there is an abnormality in the function of the platelets, so we expect that the platelet count is not affected. Again, and the PT and APTT are also both normal, but the bleeding time may or may not be affected. In most vascular diseases, they are not exactly related to platelets or plasma defects. The most common symptom that we will encounter is abnormal bleeding, in the skin because of increased blood permeability. Laboratory tests can be performed to exclude the possibility of problems related to coagulation or platelet disorders. Most of the patients will show a normal hemostatic testing, even in the presence of history of physical exam that suggests substantial bleeding. Platelet disorders are categorized into the following: quantitative, qualitative, or morphologic. For quantitative disorders, these refer to an increase or a decrease in the number of platelets that are found in the circulation. So by thrombocytopenia, we mean decreased platelet count, and by thrombocytosis, there is an increase in the platelets. For qualitative disorders, they are usually because of an abnormality in the appearance, the function of the platelets. For morphologic abnormalities, we may encounter platelets that are bigger than normal, platelets that are too small, or platelets that are without the presence of granules in their cytoplasm. The normal platelet levels in the blood is between 152 to 450 10 to the 9 per liter. Usually there is no increased risk of bleeding unless the level is below 50 times 10 to the 9 per liter. There is a higher risk of severe and spontaneous bleeding if the platelet count falls below 10 times 10 to the 9 per liter. And this is manifested by the presence of petechiae or bruising or the rashes, skin rashes that are observed when there is very low platelet count. There may be bleeding in the mucous membranes, which are found in the gastrointestinal, the genitourinary tract. There may also be bleeding in the central nervous system, and bleeding time is related to the platelet count. So that means if the platelet count is low, the bleeding time will be prolonged. Thrombocytopenia may be because of abnormal platelet distribution, deficient platelet distribution, or an increase in the platelet destruction. About 30% of platelets in the blood are found in the spleen. They are being held in the spleen. So if there is an increase in the size of the spleen, like in case of splenomegaly or hypersplenism, there will be more platelets that are sequestered by the spleen. So that will result in thrombocytopenia. It will result in thrombocytopenia. And this takes place in cases of infection, inflammation, hematologic diseases, and tumors or neoplasias. Reason why there is thrombocytopenia is when there is a decrease in the production of platelets in the bone marrow. If the bone marrow is unable to deliver enough platelets to the circulation, so that leads to thrombocytopenia. This happens as a result of hypoplasia of megakaryocytes, which may be caused by drug or radiation therapy, so during chemotherapy, and when there is generalized bone marrow suppression. So there are some drugs that can cause the bone marrow to be suppressed. Next is acquired aplastic anemia. So again, this may be related to drugs or other mechanisms. Replacement of the normal bone marrow, okay, like in cases of leukemias and lymphomas, myelodysplastic syndrome, and other neoplastic diseases, that means cancerous conditions, fibrosis, or granulomatous inflammation. So the other possibility is when there is ineffective thrombopoiesis, like in case of megaloblastic anemia. There are genetic conditions that lead to thrombocytopenia. This includes congenital aplastic anemia, Wiskott-Aldrich syndrome, X-linked thrombocytopenia, Bernard-Soulier syndrome, May-Heglin anomaly, congenital megakaryocytic thrombocytopenia, congenital thrombocytopenia with radio-ulnar synostosis or citrus, and thrombocytopenia with the absent radii syndrome. Platelets may also be destroyed. One possible mechanism is immune destruction, so which means that they are being destroyed by the presence of antibodies. Platelets that are bound to antibodies are removed by mononuclear phagocytes in the spleen. So they have some antigenic sites that bind to antibodies, and they are recognized by phagocytes, so they are removed, and they are phagocytized and removed, destroyed and transferred to the spleen. Antiplatelet antibody tests can be used to identify the presence of antibodies which are present in the platelets. Condition characterized by thrombocytopenia is ITP, which is short for idiopathic thrombocytopenic purpura. So this is caused by the presence of an autoantibody that are reactive to the platelets of the patient. So this usually affects children and adults, okay, acutely and chronically, okay, for a period of about 1 to 2 weeks in children, and there may be some remission. For adults, this is more commonly observed in women than in men. So to treat this condition, so because this is idiopathic, we don't exactly know the cause. This is treated with corticosteroids by removing the spleen, and we know already why we have to remove the spleen, splenectomy, and using the drug called rituximab. There are other reasons for immune types of thrombocytopenia. One is isoimmune neonatal thrombocytopenia. So neonatal, so this affects newborns. So this is because of the presence or the production of antibodies, okay, against the paternal antigens present in the fetal platelets. This is similar to hemolytic disease of the newborn or erythroblastosis fetalis, and this is because of, again, those antibodies that attack the HPA-1A, which is an antigen present in the surface of the platelets. So the most important condition we have to consider here is the possibility of bleeding in the central nervous system. Another one is post-transfusion purpura, which is, post-transfusion, so that means it happens after the patient receives an incompatible blood. This is most commonly observed in females, okay, who are previously sensitized, who are pregnant, or who may have received transfusion. So this thrombocytopenia manifests a week after the transfusion. So it's more of a delayed type of transfusion reaction, but the transfused and the recipient's blood are actually antigen negative, but they are still destroyed. Aside from the presence of antibodies that can attack the platelets, there are also drugs that are implicated in thrombocytopenia. So they can destroy the platelets, okay, similar to how drugs can target the red blood cells. So this will result in excessive bleeding and the manifestations of excessive bleeding, which includes some of the things that we have mentioned, like bruising. If we are to remove the drug from the system, so that will result in the cessation of thrombocytopenia and bleeding symptoms. So in short, it will be back to normal. Heparin-associated thrombocytopenia, which can either be immune or non-immune related. So the reason why heparin can cause thrombocytopenia is because heparin can activate the platelets. So when the platelets that are present in the circulation are activated, they will decrease in number. So this is thrombocytopenia. This can also be immune related to the destruction of the platelets. So that means that there are antibodies that attack the platelet factor number 4, okay, in the heparin complex. So they attach themselves to the surface of the platelet, which causes the destruction of those platelets. Okay, and it increases the platelet clearance or the removal of platelets from the system. Aside from what we have already mentioned, there are other conditions that may result in thrombocytopenia. So, for example, in cases of collagen diseases, autoimmune disorders like systemic lupus, erythematosus, RA, rheumatoid arthritis, and lymphoproliferative disorders like HD and CLL, infections with some viruses like Epstein-Barr, HIV and cytomegalovirus, and septicemia. So these are possible causes of thrombocytopenia. It should be destroyed as a result of the following: disseminated intravascular coagulation, thrombocytopenic purpura, hemolytic uremic syndrome, paroxysmal nocturnal hemoglobinuria, and mechanical destruction because of artificial heart valves. So the opposite of thrombocytopenia is thrombocytosis. So this is when the amount of platelets exceed 450 multiplied by 10 to the 9 per liter. If you see the more than 20 platelets for every 100 blood cell, okay, in the oil immersion field, so that means that there is an increase in the platelet count. So this is maybe because of an increase in the production of the platelets in the bone marrow. So that means there is an increase in the megakaryocytes in the bone marrow, and primary thrombocytosis include CML, okay, and myelodysplasia. For secondary thrombocytosis, this may be a form of reactive thrombocytosis, or there may be an increase in the number of platelets because of the presence of other diseases. And another one may be transient thrombocytosis, so that is a temporary increase in the platelet count. Right, so qualitative platelet disorders, so this has nothing to do with the number of platelets present, but instead, so there may be some alteration in the normal characteristics of the platelets, maybe an increase in the size or in some of the qualities of the platelets. The symptoms are highly variable, so it can be asymptomatic to mild, easy bruisability to even severe life-threatening hemorrhage. So the types of bleeding can be in the form of petechiae, in the presence of, simply the presence of bruising, the presence of bleeding in the mucous membranes, in the gums, and in the GI tract, the genitourinary tract, and bleeding, excessive bleeding or prolonged bleeding resulting from trauma. We have already explained this in one of these slides in this presentation. So they are categorized into the following. The first set of platelet disorders are because of a defect in the platelet vessel wall interaction. So in short, something to do with the functional defects. So disorders of adhesion like von Willebrand's disease. So if you remember, von Willebrand's factor is something like an antigenic structure in the platelet membrane. Next, Bernard-Soulier syndrome. So again, this is the problem here is there is a deficiency, there is lacking in the amount of this substance called GP1B, okay, 9 and or 5. So defects in collagen receptors like GP1C2A and GP6. So another set of platelet disorders result from the defects in platelet-to-platelet interaction. So that means they are unable to aggregate or stick to each other, like in case of congenital fibrinogenemia, so which is because of a decrease in the plasma fibrinogen level, or Glanzmann thrombasthenia. So this is because of lack of or defect in the GP2B or 3A-3A complex. Another set of defects may result from platelet secretion, defects in platelet secretion and signal transduction. So there are certain disorders that result in impaired secretion of the contents of the platelets. If we recall, so for example, ADP, so if it's secreted by the platelet, it will result in aggregation. However, because there is an impairment in the secretion of the contents of the platelets, it will result in abnormality in aggregation. So there may also be abnormalities in the granules. For example, so deficiency in certain components of platelets, like alpha SPD, delta SPD, alpha delta SPD. So next is defective platelet coagulant activity. So, for example, when the clotting factor 5A, 10A binding is decreased, and when the 8A and the 9A binding are slowed down, so this is because, secondarily, because of the platelet activity. Right, so we can see the summary of the problems associated with the qualitative function of the platelets, primarily because of either deficiency or abnormality in the process and the composition of these structures that we can see here in the platelets. So letter A is Bernard-Solier syndrome. So you can see there that in the membrane of the platelets, it's unable to attach itself to the von Willebrand's factor. Okay. Letter B is in the von Willebrand's factor itself, so there is a problem for the platelet to attach itself to the blood vessel wall. Letter C, Glanzmann thrombasthenia. Where is that? So there is a defect in the ability of platelets to interact with other platelets. Storage pool disease, letter D. So yeah, so there is a problem with certain components. Then defective thromboxane A2 synthesis, which is one of the components of the platelet granules released by platelets. Letter E. Gray platelet syndrome, letter F. So again, it's something with the problematic composition of the platelets. And defective, letter G, defective procoagulant activity. We have described this earlier. Von Willebrand's disease. Von Willebrand's factor is a component, one of an important component that is required for platelets to adhere to the blood vessel wall during during bleeding. So if it is deficient or if it is uh, altered in a way, so it can result in this condition called von Willebrand's disease, which is ineffective binding of platelets to the blood vessel wall. Acquired qualitative platelet disorders, so these are conditions that results in problems with the platelet functioning. So you can see some lists. Number one is chronic renal failure. So platelets become defective because of uremic plasma. So that an increase in nitrogenous materials in the plasma can lead to this problem. And in order to correct this problem, we can perform dialysis to normalize the amount of nitrogenous waste in the blood. Cardiopulmonary bypass surgery results in thrombocytopenia. It leads to abnormal platelet function. Platelet defects may be because of platelet activation and fragmentation in the extracorporeal circulation. So that means when the blood is outside the circulatory system, which happens when, during the bypass surgery, blood has to be controlled continuously circulating outside the body. Then liver disease. So this is primarily because of splenomegaly from portal hypertension. So there is an increase in the blood pressure in the liver resulting in splenomegaly. Paraproteinemia, so an increase in paraproteins. It results in clinical bleeding and platelet dysfunction. Here we have some hematologic disorders that lead to abnormality in the functioning of the platelets, like in chronic myeloproliferative disorders. So it can lead to either bleeding or thrombosis and abnormal platelet function. In leukemias and myelodysplastic syndromes, again, it can lead to bleeding, and this is primarily because of thrombocytopenia, and it may also be because of abnormal platelet function. And then we have this proteinemia, so which means the production of abnormal proteins, like in multiple myeloma, that's the MM, and Waldenstrom's macroglobulinemia, so the production of large antibodies. So the reason is usually because of thrombocytopenia, leading to bleeding. Next, drugs. So there are some drugs that can affect the function of the platelets. We have mentioned of aspirin and NSAIDs also. So the only drug that can cause a problem with the platelet function is aspirin, leading to excessive bleeding. So aspirin works by inhibiting platelet aggregation and secretion. So again, it can alter the stickiness of the platelet. That is why it alters the function of the platelets.